This is Dr. Bruce Samuels from Cedars-Sinai Medical Center, and today I'd like to share with you an interesting case we had of a patient who came in after cardiac arrest where functional assessment really helped out with the case. This patient was a 68-year-old female without any prior cardiac history. She had chronic renal failure, was on hemodialysis, had diabetes, anemia, asthma, and hyperlipidemia. And one day on dialysis, she became severely hypotensive and bradycardic and ultimately had a cardiac arrest. She quickly had 15 minutes of ACLS performed, which ultimately led to a successful resuscitation, and she was picked up by the paramedics and brought to the emergency room. On her arrival, her troponin was positive at 2.5, and EKG showed dramatic T-wave inversion in the anterior leads, but she had no ST segment changes. In this first angio, you can see the patient's left coronary angiogram in an LAO projection. No left main disease was seen at all. In the next view of the AP cranial, you can see that the LAD has a moderate stenosis in the mid portion. This was in fact the only significant lesion of note, and certainly was concerning. I read this angiographically as a 50 to 70% stenosis. And there clearly is TIMI 3 flow distally. I can tell you the right coronary artery was completely unremarkable without any flow-limiting stenosis identified. So at this point, I think it's a very reasonable question to say, what would you do at this juncture? One reasonable option would just be to empirically stent the LAD, given her dramatic presentation. Another reasonable option would be to say, I don't think that this lesion was tight enough to lead to a cardiac arrest, and to proceed with treating the patient medically for underlying non-obstructive coronary disease. And a final idea would be to treat the patient only if functional significance was documented using a pressure wire. And I decided to go with the last option. As you can see on this next slide, with a wire distal to the lesion in question, the minimal FFR obtained was 0.87 during maximal hyperemia after 2 minutes of continuous IV adenosine intravenous infusion. So in conclusion, I think this is a very interesting case for several reasons. First of all, I think it clearly showed that FFR could be critical in helping to decide whether or not an intermediate lesion was functionally significant. In this particular case, it was particularly important because this patient presented so unusually with a very serious yet difficult to understand clinical event. She had profound hypotension and bradycardia, which would not immediately make you think of an ischemic arrhythmia, yet coronary disease certainly needed to be ruled out. Because she had ST segment changes, which we weren't sure were secondary to ischemia or reperfusion, we felt it was imperative to have a diagnostic angio to sort this out, and we're left with an intermediate lesion and a lack of clarity about how to proceed. Without FFR testing, I think it would have been very difficult, if impossible, to know for certain that you were making the right call. But following the FFR determination and treating the patient medically, we had a good level of confidence that she would be fine as long as her hemodynamics were more appropriately monitored during subsequent dialysis therapy. In fact, in the future, the patient did great, had no further episodes of hemodynamic instability or evidence objectively of any ischemia.